Good afternoon and welcome to Policy Exchange for this event. My name is Robert Eade and I'm Head of Health and Social Care. We are delighted to be hosting this discussion in partnership with Livi, which is considering the future of general practice. We've assembled a top panel of speakers to debate the question, which I'll now introduce. So starting immediately on my side, we've got Dr. Claire Fuller, who is the Chief Executive of NHS Surrey Heartlands. For the 5 years previous to this, she was the Senior Responsible Officer for the Integrated Care System. In November of last year, Claire was invited by Amanda Pritchard to undertake a national stocktake of how primary care can be best supported within the new system architecture, and the final report was published in May. Claire has also been a practicing GP since 1995, working in both Surrey but also a spell in Northumberland, where she worked in a single-handed rural practice. Next to Claire, we have Jacob Lant, who is Head of Policy and Research at Healthwatch England. Jacob has been part of Healthwatch Network since its launch in 2013 and has been leading the policy research function since 2015. He is a committed believer in using feedback from people receiving care to improve services and has led the Healthwatch Network in shaping national health policy on everything from NHS dentistry, which is a big issue at the moment, to improving mental health support for new mums and dads. And most recently, he's been feeding into the refresh of the NHS long-term plan. Next to Jacob, we have Professor Martin Marshall. Martin is the chair of the Royal College of General Practitioners, at least until towards the end of this year, having been first elected to that post in 2019, having previously served as vice chair for external affairs. Martin is a GP in Newham in East London and Professor of Healthcare Improvement at UCL. He's also held roles of Deputy Chief Medical Officer and Director General in the Department of Health. And I think it was announced recently that you'll become the chair of the Nuffield Trust in September. And lastly, we have Declan Mullaney, who is Head of Policy and Public Affairs at Livi. Declan has over a decade experience in healthcare policy, working across a wide range of organisations, including providers, life science companies and royal colleges. Livi is part of Europe's largest digital healthcare provider, delivering digital primary care services to over 10 million NHS patients. Now, we are going to break away from convention in terms of a panel discussion by not asking the panellists to deliver any formal opening remarks. We want to use the time that we have together to get into a discussion on the solutions, because it feels like that's the most important use of everyone's time. But to set some of the context, my colleague Sean, who has surreptitiously emerged in front of us, is going to set out a very brief snapshot of some of the issues.
Well, many thanks, Rob, and welcome to all of you, both in person and online. So it can often seem like there's little agreement about the future direction of travel for general practice, but there is, however, consensus around a number of its present challenges. So I wanted to just briefly outline some of these, all of which are interrelated, in order to give the panel to delve into possible solutions. So firstly, many areas are caught in a cycle of under-provision. Secondly, there's a mismatch between workforce supply and user demand. Third, service users are clear that it is access, particularly struggles booking appointments in a time frame and means that they prefer, that it is their number one gripe with current provision, and continuity of care is in decline, despite its importance and value both clinically and culturally to patients and to GPs. Now, it's hard to generalise about general practice. I mean, that's one of the reasons why policy solutions are often so tricky to find. The scale of the challenge varies across the country, but too many areas are caught in a cycle of under-provision. Many are understaffed or under-doctored, or have a stark patient-to-practitioner ratio, meaning that there's a greater access challenge and a greater struggle to attract new recruits too. And there's also often been an intergenerational issue for some areas. A number of organisations have sought to map these disparities, but there's real complexity here because you have disparities across former CCG boundaries and right down to almost a local neighbourhood level. There's a mismatch between supply and demand. So whilst 4,000 GP trainees were accepted this year, which was up from just over 2,500 in 2014, the situation is that there's not enough arriving GPs to backfill those that are leaving. And the decline in the number of GP partners in particular over the last 5 years is particularly notable. It's clear, moreover, that whilst there is much promise in the expansion of multidisciplinary teams, time and resource is going to be required in order to fully embed those within general practice. Heightened demand. The latest data release from NHS England shows that there were 27.5 million GP appointments in May, and that's more than 4 million more than the same month 3 years ago, so quite a large increase. Of these appointments, just under half were delivered by GPs and just over 20% by practice nurses. It's clear, however, and this was certainly the case with the work that we've done in this area, that demand in general practice is quite poorly understood, and failure demand, as we put it, is unquantified. And there's a growing premises problem. Whilst ownership can be an attractive feature of partnership, which is often dependent upon geography, liability and the risk of being the last partner standing, which was identified as a major challenge, for instance, in Dr. Nigel Watson's partnership review, is clear. And moreover, a significant proportion of the estate is ill-suited for new models of integrated care. And both the Naylor review in 2017 and Dr. Fuller's stocktake make this clear. Challenges booking appointments and accessing care. So if we want to understand the service user perspective, 2 recent authoritative surveys provide a clear but concerning response to this question. The British Social Attitudes Survey, published in March, reveals satisfaction with general practice at its lowest level since that survey was first conducted in 1983, with waiting times identified as their main gripe. The GP patient survey, meanwhile, from earlier this month backs that up and reveals that only half of users find it easy to make an appointment via the telephone, which is significant because 85% of appointments are booked via that channel. And perhaps most concerningly, 26.5% of those needing an appointment avoid making one because of those access difficulties, both perceived and real, I would suggest. That survey also reveals a decline in continuity of care. It's now just a minority, 43.4%, who say that they have a GP that they regularly see. And that's a 10% decline in just 4 years. So many in this room and online will recognise these challenges, and indeed you'd be able to add many more to the list here. But ultimately it's in finding solutions where views will differ most markedly. Now, part of the solution can be found in system working, and this was articulated most effectively in Dr. Fuller's recent stocktake, which all 42 ICS chief executives have endorsed, with its central concept of integrated neighbourhood teams which wrap around general practice, aiming to ensure both continuity and to improve urgent access for those that need it. And that report identifies workforce, premises and data as being the 3 key challenges that we need to tackle to realise the vision. But there are areas of further debate too, which were beyond, or some of which were beyond the stocktake, and that these ultimately boil down to finding the right balance between national, system level, and local or neighbourhood policy initiatives and solution, and the right interplay between these. The merits and detractions of different provider models, particularly the merits or detractions of working at a greater scale, which is a pretty heterogeneous concept in terms of how it's applied currently, and also the interplay with wider system pressures. Now, Policy Exchange reflected on some of these challenges and set out some of our own suggestions in a report that was published in March this year called At Your Service. There are copies at the back, and also you can download a copy via our website. But ultimately, you're here to hear what our panellists have to say, not me. And so with that, I'll hand back to you, Rob.
So I wanted to pick up on that point that Sean said about patient experience. We've seen some big declines in satisfaction in both the BSA survey and then last week's survey results. I want to put to the speakers what's the best way of turning that around. And Claire, maybe I could come to you first.
Thanks, Rob. So it was one of the things that came through in the stocktake all the way through was not only, the 2 things were access and continuity, and that was about patient experience of both and also professional experience of both. We're having spoken with all of the ICS leaders and having engaged really widely as part of the stocktake, so we had extraordinary levels of engagement. So 12,000 people accessing, individual people accessing the Crowdicity website. We had 1.5 million hits on Twitter. We had more than 1,000 people involved in the work streams as we worked through the programme. And there was consensus around the 2 things we need to do better were access and continuity, but also how we handle that differently. And Sean already spoke about the neighbourhood team. So I think we're really clear what the problem is, but we need to start to move into how we make it better for people and how we can show that things are getting better. And that's around the construction of the neighbourhood teams and also the place teams and bringing organisations together to work in a different way. So delivering care for people where they live in a way that it's delivering population health care rather than delivering organisational siloed care.
Thank you, Claire. Jacob, how can we turn it around?
So I'm going to start with access. I think, as we heard from what Sean was saying in the stats, one of the big issues is getting through on the phone. That is obviously, if we can make a change there, I think there's a very visible, very real, very immediate change for people using primary care today. And that's not something that's a big grand picture for the future. One of the things I think we haven't done is really assessed how we update the telephone systems, let alone all the back end of what type of appointment you're booking or where you go, but actually how those telephone systems are working, and are we putting enough money and technology into developing those systems? I don't think we are. The response to the GP patient survey from NHS England was, we're spending X million on telephone systems. I have no idea whether that's anywhere near what we need to spend on telephone systems to help GPs on the front line. So that's the first thing, is around access. I think the second thing I would suggest around changing the narrative at the moment is how we talk about choice. The way that that a lot of primary care is managing demand at the moment is by restricting choice. And I can understand the reasons that we do that. So that might be not always offering patients the choice between face-to-face or a virtual appointment. It might be not giving a specific time slot for a telephone appointment. And we do that to manage demand because the system is under massive pressure, but that way of managing it causes massive frustration for people. Actually, if we put more choice in the hands of patients to be able to decide which route of care they go down, and they've got options of how long they might have to wait for different types of care, then I think that will reduce the frustrations, and more choice helps us manage demand, not the other way around. And the last thing I'd say is about reputation. If we can fix that basic access, logistical problems we have, and then we fix the choice problem, maybe we can turn around this reputational damage that we're doing to GPs at the moment. We heard that a significant number of people are not going to the GP. They're putting it off because they think it's too difficult. It's up 31% on last year in the GP patient survey. That's a massive rise in 1 year of people putting off. That demand either goes elsewhere in the system, or it doesn't go anywhere and the problems get worse for the person, and it creates more burdens for the future. So I think we really need to get those access and those choice problems can really help us solve the reputational issue and build a more positive position for the future.
It's very clear. Good action plan. Martin.
So the results of the National Patient Survey were extremely concerning, but not very surprising. What we've seen is general practice under increasing pressure for at least the last decade. Practices have worked really hard to try to maintain standards, and perhaps to many people's surprise, that's been reflected in the ongoing fairly high level of satisfaction right up until this year. So the fact that things have suddenly gone bad, I think, says something about the nature of the challenge here. In terms of solutions to address the access challenge, the simple answer is don't just focus on access. This is more than an access problem that we've got here. We've got a problem here where demand is greatly exceeding supply, not just demand, but need. What general practice can do is greatly exceeding the supply, particularly the workforce supply, and that's of both doctors and other health professionals as well. So the answer is to focus on that supply side. We need solutions to the workforce crisis. That's partly about increasing recruitment, although recruitment is probably one of the small successes. It's certainly about improving retention, and it's certainly about working more cleverly on the health professional other than doctors workforce to help them to come into the workforce and be properly looked after within the workforce. We know at the moment that we are increasing the number of physios and nurses and others in the primary care workforce, but we also know that they're not particularly happy. They're not working in an environment in which is conducive to their development. Primary care is quite a scary environment to work in when you come out of hospitals or when you come out of training. You need a good induction, you need good mentorship, and general practice isn't a conducive environment in order to provide that at the moment. So we need to work much more carefully on supporting those. If we do those things, we can increase the size of the workforce, and then we can address not just the access problem. Access is really important, but actually there are other fundamental elements of quality, including most fundamentally safety, but also personalised care and effective care, all of which are being damaged by the crisis that we're in at the moment.
Great, thanks. I know we're keen to come back to that workforce point towards the end of the discussion, so we'll definitely be able to get in some of those details. Declan?
Yeah, so I think while the BSN GP survey obviously doesn't paint a very rosy picture, it's not a uniform picture. Some regions are performing better than others. I think what's notable is being sort of willingness post-pandemic to embrace online consultations. There's a YouGov tracker that has been following this for some time that shows around 60% of patients are very happy to have a video consultation over a physical consultation. And that's remained pretty consistent, whereas 35% would rather have a physical consultation. So of course it's not for everybody. At Livi we have our patients, 94% of them are satisfied, and the reason they are is that they have timely access through a format that works for them. So I think that correlation is clear. On the continuity of care piece, we often sort of look through this issue through the lens of continuity being about physical care. Walking into a GP practice, they know you, they know your family. But I see there's lots of very positive examples where digital is enabling continuity of care, not just at Livi, but across the piece. So I think that's worth highlighting. Also, in the policy exchange report, it notes that continuity of care is much more about more than just the physical clinician sitting in front of you, but around the continuity of information flow and how that data gets into the clinician's hands. So if we are moving to a system of multidisciplinary teams and neighbourhood teams, then actually getting up-to-date, consistent information that travels with the patient is the way of creating a collective continuity of care package. That's quite fundamental, I think.
That's really interesting. I want to pick up directly on that point actually around the continuity debate, because there has been a lot of discussion. It's something that's come up prominently in the Select Committee's inquiry, for example, or around different levels of continuity and the weighting that we should afford to it in policy planning. Claire, this was something you looked at in the stock take. What's your view?
So continuity is at the heart of the way we deliver high quality care within the NHS. And I think actually it's been one of the topics that's come out as we've been talking about sort of stock take implementation. It's come out more clearly, I think, the importance of it. So we talk about neighbourhood teams, but the neighbourhood teams are absolutely to wrap around practices where the lion's share of continuity will still happen. So I've been a GP for a very long time, and I became a GP because I wanted to deliver cradle to grave care for a population in the place where I lived when I started. And when I started, we didn't have computers, we didn't have mobile phones, and we did everything. The senior partner delivered the babies, you would visit people in hospital, you would visit people at home. It was proper cradle to grave care. And then having spent time in Northumberland in single-handed practice, you get the absolute privilege of understanding people's lives in the context of where they live and how important that is to people. So we protect that. If we don't protect that, we lose the essence of what keeps the NHS going. And the number of GPs in the room and up here, the bit that is magical for me about being a GP and a general practice is when somebody comes in to see you and they've come in about their elbow, which is, I've had tennis elbow for 3 months, but then they get up and they put their hand on their door and they go, and while I'm here. And we all know that the while I'm here is the reason why they've come in. And when you fix the while I'm here is actually you help the person in a way that you probably hasn't anticipated. So we must protect that continuity. In the stock take, we talk about within the neighbourhood teams the importance of integrated urgent care, prevention, and the management of complex patients. So there are some people who have such complex needs that actually we require continuity of team. And your point really about the continuity data is really well made, because actually we need to make sure it's a single record, a single data set that unites people around it. But as somebody that has complex needs, you need to be able to know who to access. You need to be able to access them in the same way, and you need to have the assurance that that record is seen by everybody that is looking after you. So for me, continuity is at the heart of the NHS, and it's what keeps and it stops the NHS from becoming transactional and over-medicalised. So I think we protect it, and it's that balance off between how we free up the capacity to make sure we continue to do continuity by removing some of the transactional work where people would choose. So like my children don't care who they see, or if you've got a baby with a really high temperature, again, you don't care who you see, you just want to know that your baby is okay. Or if you've got a weird rash, you just want to know it's not infectious. You will trade off immediacy versus the continuity in some instances, and we have to allow people to choose to do that.
And that should, just to ask one follow-up, because I know there's an argument that almost you need to build up that relationship over many years in order to derive the benefits of relational medicine. I think the Norwegian study said it was around 15 years where the dividend really started to kick in, for example. Obviously with list sizes of 1,200, it's much more feasible. But how can you make, from a policy planning perspective, can we make condition for that flexibility in choosing that this is an urgent, one-off episodic thing that I can give to a different type of team?
Yes, so in an ideal world, you would go back to where I started, in that you would have that complete one-on-one, but we just haven't got enough GPs to do that. So there is an element of needing to risk stratify out those people for whom it's safe. What you have to watch for is those people that choose to access care in an episodic way who need continuity, and those will be our most vulnerable. So those will be our people that live in fear, our people with complex mental health issues, our people with drug and alcohol issues, and it's making sure that we've got a way of highlighting those people that choose to access episodically and give them continuity.
Martin, do you want to come straight back in, and then I'll go to Jacob? You've snuck in on the
inside
lane there.
I did. So I'm so pleased that we are now talking about continuity in a way that we haven't done for many years, at a time when continuity is definitely deteriorating. We know that, partly as a consequence of societal change, but also partly as a consequence of policy decisions that have been made in recent years. So if I can just very quickly just reiterate the evidence, because it's so powerful. So there's international evidence across a whole range of health systems and across 30 or 40 years that demonstrates that if I see a patient who I know and who trusts me, they're more likely to be satisfied by the consultation. They're more likely to comply with any advice that I give them. They're more likely to get better health outcomes. They're even less likely to die. They're less likely to go to emergency departments, less likely to be admitted to hospital. The overall healthcare costs are lower, and I'm happier as a clinician as well. So if there were any pharmaceutical intervention or surgical intervention that was as powerful as that, I can absolutely guarantee it would be built into a system. So there's something about the way that we describe continuity that has stopped that happening, which really concerns me. So that's why I'm so pleased that policymakers are getting it at last. It really is fundamentally important. We do need to think differently. The old model of continuity of care, the model that Claire and I were brought up to, was essentially one GP, one patient for 40 years. That was the model of continuity. Nobody can deliver that, and for societal reasons and for reasons of mobility and lots of other reasons as well. So we need to rethink it. Partly that's about, as Claire says, identifying which patients are most likely to benefit from continuity. So rather than delivering it for everybody, try to differentiate between relatively transactional care and care that really benefits from relationships. It's not as easy as Claire describes, because even when I see somebody with a sore throat, I use my relationship in order to persuade them they don't need antibiotics. So we use it all the time. But that's one thing. Second thing, team-based continuity. So rather than continuity with an individual GP, what we're talking about often, and we see examples of this around the world, but increasingly in the UK, of two job-sharing GPs and a nurse and an administrator working together to deliver care for 3,000 patients or whatever. So that I think is really important as well. And then the third one, which addresses your point about continuity can only really be delivered if you've known someone for 15 years. In fact, the evidence is you see a benefit after 2 to 3 years. But I think we need to recognise that whilst ongoing relationships are an important element of continuity, sometimes you can develop highly personalised care, you can develop trust just by being a really good clinician. Understanding people's psychology, understanding the sociology of interactions, all the things that GPs are trained to do, it's possible to develop what we're calling speed relationships. So really quick relationships in which you can develop some strength as a consequence of doing that. Now, they're not going to be as powerful as a traditional relationship over many years, but they're still effective. So what we need to do is recognise that healthcare in general, general practice in particular, much of it is very relational in its nature. It's not transactional. It's not like doing a technical procedure and then walking on.
Thanks, Martin. Jacob, I'll come to you, but I'll be also intrigued. We've focused most of the conversation so far on general practice, but obviously there's an interface with secondary care as well, where people need to go through from referral. So thinking about continuity in that context as well would be interesting if you have any observations from what you hear from patients.
Oh, curveball. Sorry, firstly I'll just say it's great to be on panels like this, because I remember being on panels like this 5 or 6 years ago when the continuity of care conversation was completely different. It was still talking about that traditional model. And one of the things I think has been really good in the Fuller review was actually understanding that patients also are not, you're not patient A that needs continuity of care and patient B that needs episodic care. You can shift between the two, and you can be receiving continuity of care for some conditions and have an episodic need for something else. Actually accepting that in policy terms opens up a range of possibilities for us. However, I do think there are some risks about your connection and your relationship with the practice, which matters. So I think, if we created an episodic primary care system that's a mass call centre that you ring, actually that that creates a disconnect to your GP practice. A disconnect then breaks down your relationship, your front door into the NHS, and we really need to think about that carefully for people, because all of that relates to your continuity of care. Do you feel you have a relationship with the NHS, not just you have a relationship with your GP or even your practice? It's and that's what other organisations, other companies work on. They have a relationship with their customers. We don't like that word in the health world, but actually that relationship management is important, and that goes to the heart of continuity of care. How it relates to secondary care, people get bounced between primary and secondary care all the time. Like, we're trying to track down where the referral's got to, has the referral even been sent, where am I on the waiting list, and people are pinged between GP land and hospitals to find out. I think the investment there comes in the admin support in the NHS. Actually, that doesn't need the GP to be chasing up the referral, doesn't need the GP time to be answering the telephone call. What it needs is trained, supported, supervised admin staff to help patients in their journey between primary and secondary care, so that they feel like it's one service. So it's joined up, it's integrated. Patients should be a seamless experience. They shouldn't have to know that the GP is a private provider running a contract for the NHS, and the trust is one of, part of a provider collaborative or whatever nonsense it is for the user. They just need someone to support them, and that's where I think investment in our admin and our support staff in the NHS is something we don't talk about enough. We talk about a shortage of GPs, shortage of nurses, a shortage of every clinical profession, but never the shortage of admin staff, and I think that's something that we really need to think about.
Yeah, certainly when I spent a day shadowing at a GP surgery in Watford, I gained renewed appreciation for the reception team particularly, and how vital that role is. Declan, you mentioned before that digital has a role in this. What are the offer and what are the benefits?
Yeah, again, picking up on that more nuanced position around some people who value continuity of care for their ongoing care needs may have sort of one-off transactional needs and want speedy access, of which having a digital service they can do that is a benefit. For example, at Livi, a patient can go into the app and book an appointment with the same GP over and over to build up that continuous relationship over time, something they may struggle to do for capacity reasons with their surgery. Who knows? But I don't think anybody's landed on a figure on how much of the demand out there is transactional versus complex care management. And the transactional care still needs to be, I don't have a deep relationship with my GP, but when I need to use care, I still want to have access to local services. So how do we structure a system? I know the Fuller stock take touches on this, around how do we best meet that transactional demand that frees up capacity for those patients that will get most value out of continuity of care. And I think having a more integrated digital offering, for example, can we reimagine 111 or what we can do through the NHS app? Because ultimately those patients that need episodic care needs, if they aren't able to get it through the local surgery, they will go to another part of the healthcare system. So what is the best way of giving them access to care? And I think obviously having a digital route available to them is a big part of the solution.
We could spend all the time discussing this first topic, but I'm keen to get into the second one, which is looking at disparities. So that's in terms of the variation in both the level of access and then the quality of care dependent on where you live in the country. Can I ask the panellists, what are your plans, proposals for cracking that? Because it's been I think Sean said it's multi-generational, it has been an issue that's kind of existed since the formation of the NHS. How can we finally crack this?
So it's the inverse care law that I'm delighted actually that is now being openly spoken about. So it's those areas with the greatest need often have the fewest resources available. So in the stocktake, the ask of ICS chief execs is that the neighbourhood teams will be in place for the most deprived areas by April 2024, and it's deliberate that we prioritise the areas of greatest need, and we've made the links to Bola Owolabi's brilliant work on the core 20+5 about actually identifying those areas of health inequalities for neighbourhood teams and places to work on. So I think number one, it's the prioritisation. Number two, it is the identification of how you do something about it. So we've highlighted the need for prevention. So it's the three lenses we talk about for the team. So the integrated urgent care that we've spoken about quite a lot. We've talked about the complex case management, but the third bit is around prevention and how you work with communities to actually improve inequalities in a way that matters and works for those communities. And I don't think we've been particularly good about doing that today.
Would you reform the Cahill formula though?
So the funding formula was out of scope. So 3 things were out of scope of the stocktake. Number 1 was the partnership model. Well, number 1 was the partnership model. Number 2 was the funding, and number 3 was the contract. It is really complex.
Jacob, how can we address disparities?
Well, unsurprisingly, I would start by asking the communities themselves what sort of service they want provided, because that will change massively. And I think if you just turn up with your solution and you're like shiny new building or mobile GP van or whatever it is you're going to put into the area, and you don't engage with people, then I wouldn't be surprised if those services don't get used. It's not just about providing the service; it's about understanding what the community needs, and that is partly through engagement, asking them what they want, but then also involving them in the design of the service and continual conversation about whether it's working. We've seen initiatives in the past like extended opening hours for GPs, and then people not turning up because actually the opening hours were offered at the wrong time because the community didn't know about them. So actually it's integral when these new community teams are set up that they have the capacity and the resource to do that community engagement and empower communities to do their own initiatives around health promotion and preventative measures. So it is really about those teams working in partnership with the community. And again, that comes down to, there's a lot of conversation about resource in the NHS. This stuff isn't expensive, but it gets very little, if no money, usually from the NHS and from government to fund this sort of stuff. And yet the return on investment could be huge. So I would start with speaking to communities about what they want.
Martin.
So building on Jacob's response, I think it's helpful to differentiate between acceptable and unacceptable variation, because there is a lot of acceptable variation which is a product of patient or community choices. So I spend a lot of time with my patients talking to them about whether they should take statins if their cholesterol is high, whether they should take antipsychotics if they've got serious mental health problems, and often they will decide not. For a range of different reasons, and that is perfectly acceptable. So if we were entirely evidence-based, science-based, if doctors were entirely rational and if patients were robots, there would be no variation because we would do exactly what we need to do for those patients and it would just get done. The fact that shared decision making is a key part of the delivery of effective care produces variation. So I think that's important to remember. In terms of unacceptable variation, it's a massive challenge. And again, a bit like continuity, at least we're talking about it now. And we're starting to come up with some solutions, although not quickly enough, because the level of variation in this country is so much more significant than in many Scandinavian countries. And that's something that we really need to work at. What we're seeing in general practice has always focused on individuals. It's relatively recently that we've started engaging with the public health model of general practice, which is long established, but something that a lot of practices haven't really engaged with. And I think a growing number of practices are really recognising the reality that a large proportion of people's care is determined by social factors, not by factors that we can determine as doctors. And they're starting to intervene using our social prescribers, for example, using social interventions rather than medical interventions, which is part of the demedicalisation that Claire referred to. So I think that's really exciting. I think a growing number of practices are starting to measure and understand the causes of inequalities in their communities as well, and starting to do things about it as well. But for this conversation, a lot of the solutions lie with policymakers, and you're right, this is about the distribution and redistribution of income. So if you were to ask me the question that you've asked Claire about the Cahill formula, my response is that's not college business, that's BMA business, but yes.
Journalists at the ready.
But yes, it needs reworking very clearly. When the Cahill formula was designed, however many years ago it was largely based on workload, not on need. We need to be distributing resources based on need. Now, it's really difficult to do that at a time when resources are really sparse. It's very difficult to redistribute resources, but as and when new resources come in, they need to be differentially given to those communities that have greatest need for them, and that's fundamentally important. In the meantime, whilst the kind of core distribution issue is being addressed, and I can't remember how long it took Cahill formula to be designed, but it was many years because it's a really complex process. We need to be using more ad hoc sources of funding, and that is happening at a local level. A lot of practices are getting discretionary funding from previously their CCG, now from other parts of the health service, in order to do things like employ nurses to go into schools to address the mental health problem of kids. That's an inequalities issue. So there are lots of ways at a local level that general practice can play a very
things we can do now.
role. Exactly.
Great. Declan?
Yeah, I think there's the huge opportunity through digital to deploy resource in a very targeted way. One of the benefits is you can have a GP based in one part of the country that's consulting with a patient in another without having to physically relocate to that part of the country in a very expensive long-term way. And often the under-doctored issue often gets framed around this region has more GPs than this region. But actually it's a much more nuanced issue than that, and access challenges are very localised. Within one area there might be a mixture of urban areas, rural, wealthy, deprived, and it's usually on a practice by practice basis where you see some of the biggest access challenges. So one of the things that we're doing with a couple of the ICSs that we work with, almost as a virtue of scale, is working with them to understand where the gaps in provision are locally within their area, where the practice is struggling the most, and then using additional digital capacity to help those that need it most. So you can be very laser focused in saying where the areas that need it and where the patients need better access and deploy it in that way.
Great. We're going to go on to the next section in a minute, but one question I wanted just to pick up with you, Claire, is just on the partnership model, which I know you said was outside of scope. But during the select committee session, you said that it is working really well in some places in the country, but not working well in others, and there needed to be a conversation around what would happen. Could you expand on that?
Yeah, so I work in Surrey and have lived in Surrey, and the partnership model in Surrey is working and is thriving, and so I would not wish to change that. There are some parts of the country where it is difficult to recruit partners, and I think we should look at how a different model in those places. So I always come back to that. If it's working, why on earth would you look to disrupt when there is so much to do anyway? But in the areas where it isn't working, we need to look differently, and I would then look differently within the members of the neighbourhood team or members within the place team to look at a different model.
So that kind of local solution that Jake talked about.
Which comes back to the just to pick up on the point about the funding. So the one of the points of having an integrated care system in ICS is that ability to flex the funding locally to areas of greater deprivation. And within the Stocktake, we do give a really good example of how they have already done that in the Leicester system. And there are a number of other examples around the country as well. So it can be done, but much more locally focused rather than doing something sort of top-down centrally.
Great. We're going to move on to the final section, which is on workforce, and then I'm keen to bring in questions from the audience. So if you could have yours ready, and that also applies to our virtual audience, so please do raise your hand and we will be able to bring you in at an opportune moment. So for workforce, I'd like your contributions to think about the both ends of the pipeline. So how can we retain the current GPs? And we hear regular statistics about the likelihood of GPs either choosing to retire early or choosing to change career. And then at the other end of the pipeline, how can we kind of make sure that the career is attractive for the future, given the future composition of trainees? And we know that there's been a change in the workforce over the past few years. And that point around multidisciplinary general practice and making sure that the value of those new roles is really felt. Claire, just because I asked on you before, I'll go to Martin and then Declan, then work our way back.
Yeah, so if I could just emphasise the importance of this as a challenge. So we know that the number of both hospital doctors and general practitioners has gone up year on year over many years, but the number of hospital doctors has risen by 35%, and the number of GPs by 8%. And in the last 5 years, that increase has been reversed. So we're talking here about whole-time equivalents. So the number of GPs, whole-time equivalent GPs in the workforce now is 2.5% fewer than it was in 2019, when the government made a commitment to 6,000 extra GPs, and 5% fewer than in 2015, when the government made a commitment to 5,000 extra GPs. So we're heading in the opposite direction here, and that's a major problem. I described earlier how, particularly as far as GPs are concerned, this is partly about increasing recruitment and partly about improving retention. The recruitment issue, we need to continue increasing the number of training places. You described earlier on, or it was described in the overview, that we've got 4,000 training places now, which is more than 1,000 more than we had just 3 years ago. That's great, but we need to carry on increasing the training places in order to make sure that tap is turned on faster, because the Bath is still emptying at the moment, so we need to do that. But retention is the biggest issue, and that's partly about less than full-time working, and it's partly about early retirement. And our own surveys within the college have demonstrated that around about 42% of GPs are planning to retire in the next 5 years, and if that's realised, that would mean 19,000 fewer GPs, 15,000 fewer full-time equivalent GPs in the next 5 years. And the Health Foundation report suggested that by 2030, the GP workforce might be somewhere between 50 and 75% of what it is now. So this is a massive crisis. There are things that we can do, and maybe I won't now, but I'd like to come back to this issue of less than full-time working, because it's one which is, I think, greatly misunderstood, but we'll come back to that maybe. But in terms of retaining the workforce for people of my generation, I'm 61 now, and all of my peer group who trained in general practice have now retired. All of my peer group in my local GP scheme in Devon, where I trained, have now retired, and looking a lot healthier for it, I must say. So this is not good, because we're losing the most experienced, the most passionate and committed GPs from the workforce, and the workforce as a consequence is the overall demographic is getting younger, and these are younger GPs, less experienced, who need a lot of support from the older people who are leaving. So one thing that we can do is, I think, put much greater emphasis on new retention schemes. We need to redesign the retention scheme, which has been very successful at a very small scale, in particular traditionally in keeping women who have children in the workforce, now expanded beyond that. There are ways in which we can design a retention scheme which I think would look quite attractive to doctors in their late 50s or early 60s. So this might be a contract that offered 4 sessions a week, maybe 3 sessions clinical and 1 session providing mentorship for the next generation of doctors. It would have to be a restricted number of patients. You're not going to get anyone out of retirement to see 50 patients a day, which is what I'm doing at the moment in my practice, and find it very difficult to deliver high quality care for them. So there has to be a restricted number of patients, and there has to be a real emphasis on providing good CPD and professional development to those individuals. So I think retention schemes are not cheap, but they're cheaper than having no GPs, and that's the alternative at the moment.
Declan, what's Livi's perspective?
Yes, well, I'll speak specifically around retention, because we have several hundred GPs that work for us. I think firstly, GPs aren't a homogenous voice. They have lots of different motivations and needs about what they want from a career in general practice. I think universally what they do want is a positive working environment, and given that the majority of GPs are in employed roles, either as directly salaried or locumed, as employers, creating that positive environment is a responsibility. Livi is the only digital provider to be rated outstanding by the CQC. Get that plug in. One of the reasons we've got rated out, or one of the categories we got rated outstanding in, was being well led and how we support our staff. And a lot of this, frankly, isn't rocket science, and it's done in lots of other sectors very well. It's around providing peer-to-peer support, helping them make clinical decisions, learning and development, simple things like running clubs, yoga, quarterly socials. They sound quite trivial, but collectively they create a much more positive working environment. And when the job's as stressful as it is on the coalface, as we all know, these things make quite a big difference. On the less than full-time working point that Martin was raising, the majority of our GPs are either working parents, particularly female working parents, semi-retired GPs, portfolio career GPs. And what they value the most is the ability to work flexibly. Many people are joining us online today and have that ability to work in a hybrid fashion. And many GPs want that as well. And there's a dividend to that. So 88% of our GPs tell us that they work more hours overall because they can work in a flexible hybrid way. So if you're a working parent, the ability to do a 4-hour shift in the evening that you wouldn't be able to do or wouldn't have done if you could only had to work in physical practice is ultimately adding a net contribution to the overall capacity in the system, which is obviously translating into appointments for patients.
Jacob? So picking up on that last point, just really interesting, if there are doctors, GPs out there who find it easier to do 4 hours in the evening because they've got care and commitments during the day, plenty of patients in that position too. So actually creating that flexibility around when the GP is working can also work very well for patients. So I think those two things go hand in hand. I'll take a slightly different tactic on the workforce conversation though. You mentioned about the multidisciplinary teams and how that angle plays in here. I'm slightly nervous about how the conversation around workforce plays out for the public, because we hear a lot of conversation about the shortage of GPs, and then we hear also this talk about multidisciplinary teams making more of the different professions in primary care. And it makes it sound like we're plugging the GP gap with pharmacists and physios. And that isn't really what we're talking about. And I think that creates it feeds into the narrative that might be out there of, don't fob me off, I want to see a proper doctor. Right? That's not the conversation we want to get into. We need to celebrate the different level of skill, and actually some of the other professionals in primary care are more skilled at specific tasks than GPs, and we really need to celebrate that, because that's the offer that we're selling to the public. So, and we know from work with Healthwatch since 2015 onwards, people are really ready for that. They really want to have that range of people that they can see in primary care. They want to see the best professional for the job. They can still get behind the fact that there is a shortage of GPs and that, support campaigning efforts to get more GPs, and that's true. But we can't be seeing as the MDTs are the replacement for the shortage of GPs, and I worry that's how it gets conflated in a national conversation about this at the moment. So I think that's what I would say on the workforce debate.
Martin, are we too obsessed about more GPs in our press statements?
No, I wanted to come back to that specific point. I agree entirely with Jacob that we are guilty as a profession within general practice, but also policymakers are guilty of not having those conversations with the public. We've kind of shied away from it in many ways. Partly from a general practice point of view, for things like going remote, for example, but also multidisciplinary working. General practice head has been so full of survival, just getting on and delivering the day job, that we haven't thought strategically, how do we help patients to understand who to access and who can provide greatest care. And I agree entirely that the workforce must be seen as an extra resource in general practice, not just workhorses. So I think that's really important. So I think general practice has been guilty of not putting enough effort into working with its local community, but also I think politicians are scared of doing so, because what they're saying to the public is, you might think you want to see a GP, but you can't have one, and politicians don't like saying that. So I think collectively we've got to work together across all parts of the service in order to have much more sensible conversations with the public about what the health service looks like and where the strengths are and how it might work in the future. We've not done that yet.
Yeah, I can see the groundswell for a public information campaign growing.
Indeed.
Claire?
I'm going to be slightly anecdotal but build upon the 3 points we've made. So if all of Martin's cohort and your 61 have gone, I'm 54 and half of my cohort have gone or have got plans to go. That is the scale of the problem that we have got here. And these are people who always wanted to be GPs, always gone through, and it's not quite every week now, but sort of regularly I will take phone calls from peers who will say, I'm going, I'm done, I've had enough. And it will be, we're all used to working hard, but it's at the end of a 12-hour day with 3-hour paperwork on the end of it, not having had time for lunch, to then bump into somebody in the petrol station and go, oh, lovely to see a GP. And it is that is seeming to be the straw that breaks the camel's back. So we are losing really experienced professionals at the moment, and we need to do something differently. And we need to create opportunities for people to work more flexibly. So I've been very privileged all the way through my career. When my children were little, I was in a practice I've been in for a long time, and so I would drop them at nursery, go in and do a 2-3 hour surgery, pick them up from surgery, and then come home. And I had a term time only contract. Now, had I not been able to do that, I would have stopped work. But you need a lot of flexibility within practices to enable everybody to be able to work in that way. And we don't at the moment have the ability or capability to do real demand capacity planning within practices to create the opportunity for people to work in the evenings or to people to work term time only. But that is that expertise, I think, that is through system working, I think we can bring into practice from other organisations within footprints. So, and the skill set of a GP is really transferable. That is the point. There are a lot of choices for people to go and work in different ways, and many of the younger generation want to have portfolio careers and want to do lots of different things, and we have to create a work environment for them to be able to do that. On recruitment, I think we need to speak better collectively about what a fantastic job being a GP is. I mean, I would do it again. I think it is a great privilege to be a GP, to have access into people's lives at the times when they are most vulnerable and have an impact and make things better. I think we need to describe the job for what it is, which is remarkable. But we need to create the right environment for people to be able to thrive while they are doing it.
Did you want to come back
just
on
very
something?
quickly on
Very
that.
briefly, and then we'll go to questions.
I just think it's because it's the challenge, isn't it, of how the profession right now is saying it's on its knees, people are leaving early, I'm so tired, I'm so worn down by everything. But it's also a great job. You should really consider it for your future. How you square those two is really, really challenging right now. So
that's why we must create the right environment to allow people to work in the way that they want to.
We'd like to hear your questions. So could I ask people to put their hand up, and then we'll bring the microphone around. So we've got one right at the front here, and then we'll go straight for 2 more questions. So if you just have, and if you could state your name and organisation, please, and then I'll go to Charlotte afterwards.
Hi, I'm Eleanor Hayward from The Times. Just wanted to ask the panel and Martin in particular about what GPs can learn, or the GP system can learn from what's happened in dentistry and the sort of collapse of dental appointments. It's kind of become impossible to see a dentist, and people have accepted that. Do you think GP appointments are going that way, and is there anything that can be done to stop it?
We'll just stop. We'll just take, and we'll just go to Charlotte next. So we'll take the 2 together.
I think what we've heard is
if you could just introduce yourself.
Oh, my name's Charlotte. I run National Voices, the umbrella organisation for charities in health and care. What we've heard is a sort of culture clash almost between gatekeeping behaviours that we have fallen into, I think, in primary care in ways that actually harm relationships between people, communities and services. And then Jacob's challenge that if you actually ask people what they want, if you're actually brave enough to personalise and share decisions, that you could maybe leave some of this very expensive and quite harmful gatekeeping behaviour behind. And I'm worried that when we talk about stratification, and certain people deserving complexity and others not, we're again introducing another gatekeeping hurdle. And what would you do? What would you in your roles do to enable people from reception roles to admin roles to call handler roles to GP roles and to system designers to kind of step out of the gatekeeping mindset? Because dentistry is one example that has ruined an entire service. You know, I can think of children and adolescent mental health services, for example, which is just entirely about gatekeeping now. You know, the entire fight is about getting in, and then there's hardly anything on offer, and then you're out again. And we can't let that happen to primary care, that all our energy is wasted on a bouncer at the front door rather than a service behind the door. So what's the challenge and support we can give to people at all levels to step out of that mindset?
Thanks. I'm also going to take one online question because I see we've got a few. Baroness Finlay, we will try to unmute you and hopefully you can ask your question live. Let's see if that works.
Fine, thank you. I hope I'm unmuted.
We can hear you.
Yes, good. Thank you very much. I also wanted to ask actually about whether there was too much onus on GPs to be a gatekeeper for the system. And that creates a tension between people who believe that they need something being done and investigated, and they've looked it up online and so on, and then the GP saying, well, that they can't or whatever. But also whether we have got far too siloed in thinking about medical careers, and whether we should be making it much easier for people to move across completely different disciplines. So move out of secondary care into general practice later on in life to do some GP sessions near to home, perhaps the surgeon who is no longer going to operate, or the anaesthetist who no longer wants to be keeping up with all of the tech involved, but wants to have a rapid, easy access, quick retraining route to come into primary care. But similarly, for people from primary care to move into my own discipline, which is palliative medicine, which used to be open to people with MRCGP. It isn't now, and yet we need so much care in the community of people who are seriously ill and facing dying, and it is the GP skill set which is ideally matched to meet those patient needs? And have we made a mistake in allowing that door to close because we had people much later on in their careers move across? So we weren't really draining the GP pool, we were actually keeping people in medicine overall, and they would then work on into their 60s because they were working in a completely different way, in a way that they then found satisfying later in life.
Thank you. Okay, so just to recap then, is general practice going the way of dentistry? What about the gatekeeper role? Are we too tied to it and we need to rethink that, and then sort of moving across medical disciplines? Perhaps if I start with Declan, if that's right, and then just move our way back along the road.
I'll touch on the gatekeeper role. I think, obviously a function of primary care is the gatekeeper into the system, is the front door of the healthcare system. What we have seen is the adoption of triage technologies to help with that gatekeeping role, to understand demand better, and to sort of give patients an option and the clear side of what demand's coming into primary care. So I don't think we can fully eliminate it, but I sort of get patients' frustration that they want access and they can't get access. I think there's much more smarter ways through technology about understanding what access we can and can't give.
Great. Martin?
Do you want to answer all three questions?
Respond to what you'd like. Probably to the journalist question though, because otherwise
these are great questions, and I'm glad you're giving me half an hour to answer all of them. So dentistry, I'm really concerned about what we can learn negatively from where dentistry is at the moment. So what we've seen over years is more and more pressure applied to NHS dentistry. Dentists finding it increasingly difficult to provide the service that they want to provide for their patients, and therefore going privately. And now we've ended up in a place where there's a very inadequate safety net service for those who can't afford to pay, and a majority of people who do pay for their dentistry care. Could general practice go that way? It could do. And I haven't got any stats, but there are a growing number of GPs who are deciding to work privately, not just in big metropolitan areas, and that worries me greatly, because the fundamental principles of the NHS around fair access, open access to all, irrespective of ability to pay, is such an important principle to my mind, such an important part of our, what's important to us as a set of values as a country, that I worry about it greatly. So yes, I am worried, and that's why these kind of discussions are so important, and why we need to implement the solutions that we've been talking about today. In terms of gatekeeper function, it's an interesting question, because when you first asked that question, Charlotte, I wasn't quite sure which elements of gatekeeping function you're referring to, because there's a number of them. So if the question is the current triage system working, let's face it, a system which was largely introduced in an emergency in 2 or 3 weeks in spring 2020, the answer is no. It's not working for anybody, and that's partly because the technology isn't good enough yet, although it's getting better. It's partly because neither clinicians nor patients have been prepared for it, partly because we haven't had enough discussions about it. So triage isn't working. It's still necessary. When demand exceeds supply, we need triage. So we need a system of triage that works, and we haven't got that at the moment. So that's one element. The second element is when people have issues related to their health that may or may not require professional services, should general practice be the gatekeeper to that? Clearly not. Health is something that happens in schools, in workplaces, in communities, in our high streets, in our libraries, in our gyms. That's where health should happen. Only a very small proportion of it should get to the expensive professionalised part of the health service, which we're part of. And then the third question is, should the gatekeeper function remain between generalist services in the community and hospital specialist services? Absolutely yes. We've got a system that's designed around that. We couldn't afford it otherwise. If we want to spend 14 or 15% of our GDP on health and have direct access to specialists, ask the taxpayer, I suspect they'd say no. There's something very important, not just about the cost effectiveness of the gatekeeper function of general practice in the UK, but actually also of our ability to demedicalise problems, to ensure that only those who need expensive resources get to them. Now, of course, there are exceptions around that, and things have changed over time, direct access to sexual health services, direct access to midwives, that's fine. But overall, for undifferentiated problems, seeing a GP first is both good for your health and good for the health system.
I think the question also asked about kind of moving in later career back into general practice, because at the moment they're split GMC registers, am I right? And a performance list. Could we change those to make those to make it more porous, I guess, for someone to change career?
So that's Laura's question, and I think it's a really important one that we as a college are considering at the moment, and I have to say it's very controversial. So historically, we as a college have advocated that anybody who works in general practice seeing undifferentiated problems should be a fully qualified GP, as in they have MRCGP, and that's what the performance list is about. So you've reached a certain standard, and we can say to the public, we guarantee that when you see this GP, they've reached that certain standard. So we, in many ways, in general practice, have excluded other doctors from working in general practice, people who aren't MRCGP, fully qualified doctors, because we believe that that's good for the quality of patient care. That isn't what's happened in hospitals. So you can work in hospitals when you've got your full CCD and when you've got your a full consultant status, or you could work as a clinical assistant or SAS doctor. So we're currently considering whether a similar SAS grade or clinical assistant grade would be helpful in general practice. My personal view, this isn't a college view because we're still deciding it, my personal view is that for undifferentiated problems, it's only right that patients should be able to guarantee that they receive high quality care from a fully qualified medical generalist. But for other problems, if you could say for long-term condition care, for care of the elderly, for palliative care, a whole range of specific issues, then actually other doctors would add value. But it is, as I say, a very controversial issue for us as a college.
Interesting that the council's looking into it though, yeah. Jacob, you've looked at dentistry.
I was about to say, for anyone who follows me or Healthwatch on Twitter, it's a surprise I wasn't the one who mentioned dentistry first today, so thank you, Eleanor. I'll go back to a point I made earlier about relationship with the practice, with your GP practice. That, for me, was the fundamental thing that's led us on the slippery slope in dentistry. So in 2006, we ended the idea that you have your dental practice. So you're not registered at a dentist in the same way you are with a GP. You can theoretically go anywhere, but that then makes access much trickier, and there's all the problems I won't go into now. So I think if we ever break the relationship between the patient and their GP practice, we could definitely end up in the same place that we are for dentistry. So that's just my comment on that. On Charlotte's point around gatekeeping, 2 points, responding to that. So I said at the beginning about giving people more choice as a way of managing demand. Actually, when we take choice away, we make people frustrated. But when we give people choice, they become experts in their own conditions, and they can route themselves through the care better. So it's all about that, how we give people sensible choices, accessing different health professionals. That might mean more direct referral into secondary care. That might mean more direct referral into all sorts of different services. And the GP doesn't need to be the gatekeeper. One anecdote I'll share on this, I had a conversation maybe 18 months ago with someone at NHS England about an online weight management program they were setting up. They wanted to hit a target of like 1 million people seen in the first, referred to it in the first 6 months or something. I can't remember what it was specifically. But it was dependent on being referred by your GP. And actually, it was an online system. Why does that need to be, why do you need to go to the GP? Yes, the GP can refer you, but why not make that direct referral? Didn't make any sense to me at all. So we need to be, whenever we add a burden onto the GP of referring into this new system, we need to really think about that. Is that the right thing to do? Or could it be offered through a more sensible sort of direct referral mechanism? So yeah, that was my point on
that. Claire, and I'll ask you to be brief, just 'cause I'm keen to get another couple of questions in if we can.
They were great. So dentistry. Dentistry, in the stock take we covered, it wasn't just about general practice, it was about pharmacy, optom, dentistry. We made a case for actually audiology should also be included within the family of primary care. Really great case studies of how dentists have identified inequalities within communities in a way that other people can't, in terms of the identification of dental carers in children. So we have now got, so as a system, we have now taken on the delegated commissioning of dentistry from NHS England. Not many places have chosen to do that from July the 1st, but that will come across for the rest of the country in due time. I think it would be really interesting how we can then bring that tie in our inequalities agenda with that localism to actually help address some of the problems. So that's the dentistry one. The flexibility of careers. So I think many secondary care doctors are already generalists, and I would agree with Martin if we had kept the undifferentiated, all GPs saw everybody all of the time, but that's not the way that we are working. So actually paediatricians and geriatricians are generalists. You have, you know as well as I do. So I think it is definitely something that we should look at, particularly in terms of fluidity of people's careers, but also in terms of enhancing the available capacity within general practice to look after the same demand. And then thirdly, I'm sorry, because this is one of my most favourite subjects, receptionists. So I think receptionists are the bit of the NHS that are most overlooked. And so receptionists are some of the lowest paid. They're not recognised by the NHS people plan. They're not part of Agenda for Change, yet they probably have more patient contacts than anybody in the NHS on a daily basis. And we need to look after, we need to create a career path. That you were talking about, admin staff within general practice in particular. We need to create it so that when you walk past your surgery on your way to school, one of your aspirations is you might start as an apprentice within a practice as a receptionist, but we need a better name for it. And then you work up through. And so Nikki Malander, who is my most brilliant director of primary care in Surrey, used to be a practice manager. We need to start to create different career trajectories for people so that they can see they can see a future beyond it being a receptionist being the job of the traditional female-only occupation as it has been.
I'm going to try and get 2 more questions in. They'll need to be really short though. We've got quite a few online, so apologies to the in-person audience. We're going to go to Steve Black first, and then I'll try and get one in the room.
Hi, can you hear me?
Yes, speak a bit louder, just it's a little quiet on the speakers.
Okay, I wanted to explore the question why, if access and patient choice are the 2 biggest problems, why are we not exploring digital solutions more? Because if only about half of practices in England seem to have any online route for digital access, and the other thing with why access and patient choice are the 2 biggest.
There's a bit of background noise there, I'm afraid. Okay, I'm gonna have to cut you off there, but I think we've got the essence of the question. So sorry, Steve. Just due to time, we'll have to move on to the next question. So, how can we grow digital provision when there's such an access problem? And then we'll go just to the lady in the middle there, please.
Thank you. So Danielle Henry, Independent Healthcare Providers Network. Slightly different question, so hopefully that will be fine. It's really around the role of ICSs and the importance of their role in delivering the agenda as set out in the fuller stocktake. So I guess ICSs seem to have a huge amount to do. This agenda is huge, complex and simple at the same time, and multifaceted. How do you think ICSs are going to be able to prioritise that when they have all the other things, such as the elective care backlog as an example? So I'd be really interested to hear everybody's view on that.
Okay, are we making enough of digital? And I imagine, Claire, you'll have some thoughts on the ICS question, but I will go back to Declan first and then give you the final word. But if we could ask for sort of short contributions, please.
Sure, I mean, on the digital point, right, it's a very varied landscape in terms of quality out there. For some patients, accessing their GP's practice website is quite a frustrating experience, often doesn't meet basic accessibility standards, versus somebody that's being able to access a fully integrated video consultation type service. So there's a lot of inconsistency. How do we get around that? I think commissioning at scale. For example, we partner with a whole range of NHS, ranging from individual practices right up to ICSs. But there is no one clear mechanism for any of those partners to commission a high quality digital service. If there was a clear, consistent commissioning framework, I think then we would see more uptake and consistency in the quality out there.
So access, I think there's no doubt that we've learned an awful lot about where digital access, digital care can add real value as a consequence of the pandemic. The shift in general practice from 80% of appointments being face-to-face pre-pandemic to now 64%, I think is probably about right. It's going to vary. It's going to vary over time. It's going to be different in different practices, but I think it's probably about right. I think it's interesting that when we talk about technology-enabled general practice, we mostly talk about the telephone that's been around for 150 years. So what is the role of videos? I think we all thought that videos would be helpful. I think the benefit of a video consultation is somewhere between a face-to-face and a telephone one. We haven't used video very much in general practice. Only 2% of, I think it's 2% of consultations are used in a video, and that's partly because the technology is still quite clunky. And therefore, in a pressurised 9.8 minute consultation, you don't want to spend 2 minutes sorting out the technology. So that's probably why I think it should be used more, and I think it will be as we get better at doing it. And I've forgotten the second question, sorry.
ICSs.
ICSs, brilliant.
We'll stop there, Martin.
No, I can't.
We don't have any time now.
So, I think the most important aspect of ICSs is they're going to help us to focus more on population health than the NHS has ever done. Now, are they going to work? Are they just another reinvention of the middle tier of the NHS? Skeptics will say they are, but should we be throwing our weight behind them to make them work, to make them deliver their potential? Absolutely we should, because population health is such an important element of what we do, and we don't do it very well at the moment. And they require a strong GP voice to work.
On technology, very quickly, I think when we use it badly, we damage the reputation of the NHS. People have an expectation of what tech can do in other sectors, and the most practical example I can give of this is when GP surgeries turn off the app for booking appointments overnight. If you're someone who can't get through on the phone at 8 o'clock in the morning because you work then, or you're on your way to work and you don't have a job that's flexible that allows you to do that, booking on the app on the way home might be really helpful. To go onto the app and find the app is now closed, which is a concept the rest of the world has no idea about. I understand the very practical safety reasons why practices do it, and it's not, it's a funny point to make, but actually the reputational damage it does to how the NHS uses tech and the trust in tech is really, really bad. So I think we need to solve those problems if we're going to make more use of tech. On ICSs, most important thing, have a senior GP on the top tier, on the ICB, in your top team. You need primary care as well as secondary care and patients, and you need all parts of the system reflected in that. And I think there's too much weighting towards secondary care at the moment. We need more GP leaders at the top of ICSs.
Claire, do we need more primary care leadership in ICSs?
Always. So just conscious of time. So the thing that's really powerful about the stock take is all 42 ICS chief execs all signed up and were involved all the way through. We had a monthly sounding board, did one-to-ones with them all the way through. We had ICS representation within every single one of the work streams, so it's absolute buy-in. The mistake to think of is that this is an add-on to everything else. It isn't. The stock take is actually about how, as ICSs, we do our business. So it's how we sort out elective, it's how we sort out admission avoidance, it's how we sort out the discharge issues. And the further away I've got from the publication, increasingly realise, I haven't said it before, but this is about how we deliver health and care to our populations in their geographies, rather than through organisations. And increasingly, I realise that to implement and to deliver it, it is a massive clinical change programme.
We're going to have to stop there. I'm really sorry, there are loads of questions online which we haven't been able to get to just due to time constraints, but I'd like you to express your thanks for our fantastic discussion in today's panel.